Hello and good morning. It is such a beautiful day outside, so I thought no better place than to teach you about schizophrenia. Okay, first we're going to talk about the pathology of the disease. Now, when talking about diseases in nursing, a lot of times healthcare providers in general, not just nurses, use a lot of big, fancy medical jargon. So I've come up with an analogy that I want to use. Now, we as a society are very in touch with phones and technology. So I'm going to say that we can think of our brains as if they are the message app on your phone. Now, normally your brain is constantly sending and receiving texts between its different parts, kind of like contacts in your phone. These messages help you understand what's real, organize your thoughts, and respond coherently to the world around you. So for example, one contact helps you hear things, another helps you interpret the meaning of messages, and another helps you decide how you react. So with schizophrenia, your messaging app is malfunctioning. Sometimes messages start arriving when no one actually texted you. So imagine getting a notification from a contact, but when you open it, no one sent anything. In real life, this can feel like hearing voices, which are auditory hallucinations, or seeing things that aren't there, so visual hallucinations. Other times, real messages get mixed up or arrive out of order. So imagine being in a group chat where texts come in scrambled, or emojis are being used instead of letters and you have to try to interpret that, or a message arrives from the complete wrong person. So it would be incredibly confusing and hard to follow the conversation. This is similar to how someone with schizophrenia might have trouble organizing their thoughts or speaking clearly. There could even be unknown contacts messaging the brain. So these messages might feel very real and convincing, even if they don't match what's happening beyond the screen. This can lead to strong beliefs that aren't based in reality, leading a person with schizophrenia to think that someone is watching or plotting against them. And on top of all of that, the brain may have trouble filtering the messages. A typical brain can silence unimportant notifications and focus on what matters. So similar to the focus mode on our phones, with schizophrenia, everything can come through at once, making it incredibly hard to focus. These changes are linked to how brain chemicals, which are called neurotransmitters, send signals. One of these brain chemicals that plays a large role is dopamine. So when dopamine's out of balance, it's like the app is malfunctioning and sending Pardon, there are some other people outside right now. When dopamine's out of balance, it's like the app is malfunctioning and sending too many alerts or tagging the wrong messages as important. So overall, schizophrenia isn't about someone choosing to think differently. It's more like their brain's messaging app is misfiring, sending confusing, extra, or false texts that make it hard to differentiate what's real and what isn't. So, what can we do to promote health or prevent schizophrenia? So when it comes to preventing schizophrenia, there isn't a one-size-fits-all way to stop it from developing. But there are some important health promotion strategies that can lower the risk. One key method of prevention is avoiding drugs that affect the brain, especially during our developmental years. So substances like marijuana, LSD, or amphetamines can increase the risk of triggering schizophrenia in people who are already at risk. So back to that messaging app analogy, if the brain's already a little sensitive, so if your app is already kind of not working properly, these substances might flood it with too many confusing texts that increase the chance of it glitching long term. Another important method is early mental health support and stress management. So high levels of ongoing stress, trauma, or unrelated anxiety and depression can put extra strain on the brain. So if someone's already vulnerable, this added pressure may increase the risk of developing schizophrenia. So teaching healthy coping strategies like talking to a counselor, building strong social support, getting enough sleep, and managing stress help keep the brain stable and resilient. So when we are doing our nursing assessment, one thing to keep in mind is risk factors. A major risk factor with schizophrenia is family history. So what we like to think of here are first-degree relatives, those being our parents and siblings. So if a first-degree relative has schizophrenia, then the risk is higher. This doesn't automatically mean that the person will definitely develop schizophrenia. Again, back to the substance use, a major risk factor is substance use, especially during the teenage or young adult years. So again, back to our marijuana, LSD, and amphetamines. And again, stress and trauma do play a large role. So experiencing things like abuse, neglect, major life stress, or ongoing anxiety will put extra strain on the brain. And then there are also biological factors occurring before or around birth. So those prenatal developmental time. Problems such as infection during pregnancy, poor nutrition, lack of oxygen at birth will affect how the brain develops, making it more susceptible to developing schizophrenia. Age is another factor, with symptoms often starting in the late teens to early 30s, and that's a time when your brain is still developing and changing. And what we know about humans is that connection with others is super important. So social isolation or lack of support can increase your risk, because we as humans rely on connecting to each other to help check reality, and without the support of others, it can be really hard to sort what's real and what isn't. So with our mental health assessment, thinking about our always send the mail through the post office, our appearance. So these clients might appear disheveled or have poor hygiene, such as unwashed hair or wrinkled clothing. Their clothing might be inappropriate for the weather. They might have a flat or expressionless face. Their speech can be disorganized or hard to follow. They might jump from topic to topic, give unrelated answers, or create new words. And in some cases, their speech might even be very minimal. So their memory might be mildly impaired, specifically their short-term memory. They might have trouble remembering recent conversations or instructions, but their long-term memory is usually intact. Their mood might seem flat or inappropriate for the context of the situation. They might seem disconnected from the situation. Some individuals might appear anxious, suspicious, or irritable. They might seem paranoid as well. Their thought processes are often disorganized. They might have delusions, strong false beliefs. Their thinking might seem illogical or difficult to follow, again, given the context of the situation around them. Perception is a big thing with schizophrenia. It's commonly altered. Again, back to those hallucinations that we talked about. They typically will be experiencing hallucinations, especially auditory hallucinations are a big thing, so hearing voices that others cannot hear. And these will feel very real to them, even though they're not actually happening. So we also like to think about orientation, which is awareness of person, place, and time. It's usually going to be intact with these clients, especially in earlier stable phases, but during severe episodes, the person might become incredibly confused or have difficulty fully understanding their surroundings. So with the nursing process and what we can do as nurses, we should assess frequently for risk of harm. So this includes asking about thoughts of self-harm, suicide, or harm to others, especially if the patient is hearing voices telling them to act. These are known as command hallucinations. And with what we do as nurses, such a big thing is safety. So what we want to do is maintain a safe environment, remove potentially dangerous objects, so sharps, cords, keep the room uncluttered, ensure close observation if the patient is high risk. We want to use calm, clear, simple therapeutic communication, because these patients can become overwhelmed easy. So giving short, direct instructions helps reduce confusion and agitation. We don't want to argue with delusions or hallucinations, so instead we can acknowledge the patient's experience while gently reinforcing reality. So For example, if they're experiencing an auditory hallucination, what we can say is something like, "I understand you're hearing voices, but I do not hear them, and you are safe here in this environment." We can also monitor for increasing agitation or changes in behavior. And so knowing the early signs are important. So pacing, raised voice, or withdrawal can signal escalation, and allowing for early intervention can prevent a situation from escalating before anyone's safety is compromised. And the outcomes that we want to look for as nurses are the patient remaining free from self-harm or others remaining free from harm in the unit. So no self-injury, no aggressive behavior, no unsafe actions related to hallucinations or delusions. We want the patient to demonstrate improved reality orientation if they are experiencing a more severe episode. We want them to kind of begin to question their hallucinations, so state things like, "I know the voices aren't real." We want them to be able to tell the difference between what's real and what's not. We want them to use safe coping strategies when experiencing symptoms, so instead of reacting to the voices or paranoia, we want them to seek the support of staff and use distracting techniques. We want them to maintain a safe environment. So we want them to follow directions. We want them to not attempt to leave the unit. And we want them to interact appropriately with others. So there are medications for schizophrenia. They're antipsychotics. We have first, second, and third generation antipsychotics. So your first generation are going to be medications like haloperidol. It's a dopamine antagonist, so it's a D2 receptor antagonist, and it targets the positive symptoms of schizophrenia. It does have disadvantages like dystonia, tardive dyskinesia, and anticholinergic side effects. It can also cause weight gain, sexual dysfunction, and endocrine disturbances. The big thing with the side effects there is that some of them are irreversible, like tardive dyskinesia. Moving on to our second generation antipsychotics, we have clozapine, which is a 5-H2A receptor and dopamine D2 receptor antagonist. And it treats both the positive and negative symptoms. Again, it does have the tendency to cause significant weight gain, and there's a risk of metabolic syndrome. So we use Geodon in combination with this for those at risk of diabetes. And then we have our third generation antipsychotics, which is going to be aripiprazole, which is Abilify, and cariprazine, which is Vraylar. And again, this is a dopamine system stabilizer, and this will treat both positive and negative symptoms while improving cognitive function. The benefit to these third generation antipsychotics is that there's a lower risk of the negative side effects such as tardive dyskinesia and lower risk for weight gain and anticholinergic effects, but the risks are still there. So with these medications, again, the big thing is that tardive dyskinesia is a big risk because it is permanent. And what tardive dyskinesia is, I keep mentioning it, and it's a big medical term again, but it's involuntary movements, especially in the face. And these medications also do come with the risk of neuroleptic malignant syndrome, which is rare but life-threatening. So knowing the signs of that is very important. And those are going to be high fever, severe muscle rigidity, confusion, and unstable vital signs for that neuroleptic malignant syndrome. So knowing the symptoms of that are incredibly important because it is a rare but life-threatening side effect with all of these antipsychotics. But anyways, with these schizophrenic clients, knowing for discharge plan purposes, having a plan for community resources and support services for ongoing care after discharge is incredibly important. So the patient should be connected to outpatient mental health services including regular appointments with a psychiatrist or a mental health provider for medication management and symptom monitoring. It's important to teach the patient and family that even if symptoms improve, they should not stop medications or appointments because schizophrenia is a lifelong condition. And if they were to stop their medication and quit going to appointments, it would ultimately lead to relapse. So basically, as nurses, we should just phrase it simply, just like keeping your phone updated so the messaging app keeps working. Staying consistent with care helps keep the symptoms under control. The patient should also be encouraged to participate in therapy or counseling, such as individual or even group therapy, because these settings help them learn coping skills and recognize early warning signs like worsening paranoia or hearing voices, and even help them build social skills, especially in that group therapy setting. And support groups can also help reduce feelings of isolation by connecting them with others who understand what they're going through and are going through similar things themselves. Another key part of discharge teaching is identifying community mental health resources. So this might include local mental health clinics or case management services, or assertive community treatment, so those ACT teams. These programs will provide more hands-on support, such as helping with medications, appointments, housing, or daily living needs. And if the patient's being discharged while they're still on a new medication and need to have like vitals and ADLs monitored, they can even enter a partial hospitalization program for a little bit closer monitoring if they're not quite ready to be discharged just on an ACT plan. But they should be given specific contact information, so phone numbers and locations, rather than general suggestions, just so that they can have the most comprehensive plan possible to keep their care as attainable as possible for them. Crisis resources are also essential. The patient and family should know exactly what to do if symptoms suddenly worsen. This includes calling the 988 Suicide and Crisis Lifeline, going to the nearest emergency room, or contacting their healthcare provider. And teaching should include the warning signs that need immediate help, such as command hallucinations. Again, those are those hallucinations that are telling them to do something harmful, such as harming themselves or others. This also includes severe paranoia or thoughts of self-harm. And education should also include the families or the caregivers. So caregiver involvement when appropriate. So family members can help monitor for early changes, encourage medication adherence, and provide emotional support. So teaching families to respond calmly, so no arguing with delusions, but gently reinforcing reality is very important. So the patient has difficulty with managing daily life, referrals to social services might even be needed. And this can include helping with housing programs, disability benefits, transportation services, so getting to those appointments that they need to go to, or vocational rehabilitation to support returning to work or school if that was something that they were doing previously to hospitalization. Finally, as with any mental illness, emphasize routine and structure, because encouraging regular sleep, meals, and daily activities in a predictable routine helps reduce stress and keeps symptoms more stable. Yeah, thank you for listening to my talk. I knew that it was a long one, but I hope that you learned something about schizophrenia.